Is your nightly PM pill quietly aging your brain? If you or someone you love is over 60, today's episode could save months, sometimes years of clear thinking. We're walking through 7 common medication categories that are linked with memory loss confusion and what many families describe as sudden dementia. We'll explain how these drugs affect the brain's simple food-first habits that may reduce your need for certain meds, and exactly how to talk with your doctor about safer options. Quick but crucial note. Before we start, this is education, not medical advice. Never stop a prescription on your own. Some must be tapered slowly and carefully. Alright, keep watching because number 6 carries an FDA-boxed warning in older adults with dementia, and number 1 is hiding in way more PM products than you think. Let's get clear on the terms everyone mixes up. Dementia is a chronic decline in memory and thinking that unfolds over months and years. Delirium is sudden confusion that comes on in hours or days, often after a new medication, dehydration infection, poor sleep in the hospital, or alcohol-drug interactions. Delirium can look like rapid dementia. And here's the kicker, repeated delirium episodes are linked with worse long-term cognition. So when a senior starts a new pill and then family notices sharp confusion, we have to ask, is this dementia progressing, or is the medication provoking delirium sedation, or an anticholinergic effect that's masquerading as dementia? That question can change a life. Now, a concept every family should know: anticholinergic burden. Many common drugs block acetylcholine, the neurotransmitter your brain uses for attention and memory. One pill may not be a big deal, but stacking 2 or 3 can push attention, reaction time, and memory off a cliff. There are scoring systems doctors and pharmacists use to estimate that burden. Your goal with your care team: reduce the total load while still treating what needs to be treated. Let's walk through the 7 medication classes to discuss with your clinician, including what they're used for, how they can affect the brain, and safer conversations to have. And if this helps you hit like so YouTube shows it to more families who need it. First-generation antihistamines like diphenhydramine, you might know it as Benadryl, and doxylamine. These are extremely common for allergies, colds, and sleep, and they're often tucked inside PM versions of pain relievers and cough syrups. They're strongly anticholinergic, which means in older adults they can cause confusion, daytime grogginess, blurry vision, constipation, urinary retention, and falls. If you hear HCl diphenhydramine on a label, that's your signal to pause and talk with your pharmacist. The conversation to ask about switching daytime allergy control to non-sedating second-generation antihistamines like loratadine, cetirizine, or fexofenadine, considering a steroid nasal spray for inflammation, and using saline rinses. Food-first angle. A Mediterranean-style diet rich in colorful produce supports lower systemic inflammation, which can reduce allergy flares for some people. Also, limiting alcohol in the evening prevents additive sedation when allergies already make sleep tough. Second, overactive bladder antimuscarinics, think oxybutynin, tolterodine, sulfafonacin, and others. If you've ever seen for bladder urgency or can't get to the bathroom in time, these are the usual suspects. Many in this group cross into the brain and add to anticholinergic burden with observational links to worse cognitive outcomes over time. That doesn't mean no one should take them. It means older adults deserve a careful risk-benefit talk. Ask your clinician if a non-anticholinergic option like mirabegron could be appropriate for you, and pair it with pelvic floor therapy, caffeine timing, and hydration strategies. Practical tip. Many people drink little all day, then overhydrate after dinner and wake up all night. Try front-loading fluids earlier, then taper in the evening. Food first, a fiber-forward dinner, think lentil soup, leafy greens, a small portion of quinoa steadies. Blood sugar so you're not chugging fluids for nocturnal thirst. Third, tricyclic antidepressants, TCAs such as amitriptyline and higher-dose doxepin. They're sometimes prescribed for neuropathic pain, headaches, or sleep, but they carry significant anticholinergic effects at typical doses. Daytime fog, dry mouth, constipation, and balance problems are common in older adults. Ask about alternatives for depression. Many clinicians favor SSRIs or SNRIs in seniors. For nerve pain, options like duloxetine, topical lidocaine, or gabapentin may be considered. If a TCA is being used solely for sleep, cognitive behavioral therapy. For insomnia, CBTI is the first-line non-drug gold standard. Food. First, for sleep, anchor your evening meal on tryptophan-rich proteins, turkey eggs, Greek yogurt with complex carbs, oats, sweet potato, to help serotonin and melatonin pathways and avoid heavy, spicy, or high-sugar dinners that can fragment sleep. Fourth, benzodiazepines, lorazepam, diazepam, alprazolam, clonazepam. These quiet anxiety fast, but in older adults, they slow processing speed, impair memory, increase fall risk, and can trigger delirium, especially with illness or dehydration. Long-term use may worsen cognitive complaints. The safer conversation is about tapering slowly if you've been on them for months and replacing them with non-sedating options under medical supervision, CBT for anxiety, SSRIs/SNRIs, buspirone mindfulness training, and paced breathing. From a food-first perspective, steady blood sugar is a real ally against anxious jitters. Build each meal with protein, fiber, and healthy fat, say salmon with roasted broccoli and olive oil, or a veggie omelet with avocado. Also cap caffeine by early afternoon. For some, even morning caffeine lingers into the evening and feeds anxiety and insomnia. Fifth, the so-called Z drugs for sleep, zolpidem, esopiclone, zaleplon. They're marketed as hypnotics distinct from benzos, but in older adults, they still raise risks for delirium, next-day impairment, falls, and car accidents with only modest improvements in sleep time. If you rely on them nightly, ask your doctor about a structured taper while you learn CBTI skills. Here's a simple 2-week starter you can try tonight while you arrange professional guidance. Strict wake time, same time daily. A 20-minute daylight walk in the morning to set your body clock, screens in bed. A cool dark room and a wind-down ritual light, reading gentle stretches, or a warm bath. If you enjoy tea, consider non-sedating options like plain chamomile or lemon balm in small amounts. But remember, teas can increase nighttime urination. Finish them 2 to 3 hours before bed. A small evening snack of tart cherry yogurt or kiwi with plain Greek yogurt can support melatonin production and reduce awakenings for some people. Sixth, antipsychotics, such as risperidone, quetiapine, and others in people with dementia. These medicines can be necessary for severe aggression or psychosis that places the person or caregivers at risk. However, they carry a boxed warning for increased mortality in elderly patients with dementia-related psychosis, and they are also associated with strokes and accelerated cognitive decline in some studies. The goal is always the lowest effective dose for the shortest time, with frequent reassessment and a strong emphasis on non-drug strategies, first identifying triggers, pain, constipation, infection, noise, overstimulation, simplifying routines, ensuring glasses and hearing aids are working and supporting daytime light exposure and gentle activity. Food first supports. Here include soft, easy-to-chew meals to reduce mealtime distress, hydration prompts, and magnesium and potassium-rich foods that aid relaxation. Spinach, pumpkin seeds, and bananas, within a balanced plan approved by the care team. Seventh, certain opioids and opioid combinations, especially meperidine and tramadol, and any opioids stacked with sedatives like benzodiazepines or Z drugs. Opioids can provoke delirium, constipation, which itself worsens agitation and dangerous sedation in older adults. If opioids are needed, the safer approach is the lowest effective dose for the shortest time, avoiding other sedatives and emphasizing non-opioid pain strategies, scheduled acetaminophen if appropriate, topical NSAIDs for knees or hands, heat, ice, physical therapy, and targeted strengthening. Food. First, an anti-inflammatory plate. Think fatty fish, salmon, sardines, extra virgin olive oil. Berries, leafy greens, turmeric, and ginger in cooking supports joint and nerve health, while you reduce reliance on sedating pain meds. And please discuss a bowel regimen proactively, hydration, prunes or kiwi daily, chia flax in yogurt and fiber-rich vegetables to prevent opioid-induced constipation. Let's pause for a quick retention break. If this is hitting close to home, drop the comment ACB so I know to make a printable checklist and doctor talk script for you. And if you've ever discovered a surprise PM ingredient on a label type, found it in the comments, your story could help someone else. Now, how do you bring this to your doctor without sounding confrontational? Try this simple script. I'm concerned about my memory and balance. I learned that some medications add up to something called anticholinergic burden. Could we review my prescriptions and over-the-counter pills together and see if any are contributing? If we find one, what's the safest first step to reduce my total burden? Bring every bottle, prescriptions, supplements, allergy pills, cough syrups, and PM combinations to the visit. Ask which single change would give the biggest benefit with the least risk. For sleep complaints, ask directly for CBTI. For anxiety, ask about non-sedating options and a taper plan if you're on daily benzodiazepines. For bladder urgency, ask if a non-anticholinergic option or pelvic floor therapy would fit your case. For allergies, ask about second-generation antihistamines and nasal sprays rather than nightly sedating pills. If you're on antipsychotics with dementia, ask how behavioral strategies can be strengthened and what the exit plan looks like. Because we're a food-first channel, here's a practical brain-forward plate that supports clarity while you and your doctor optimize medications. Start with omega-3 rich fish twice a week, or a plant-based omega-3 source like ground flax and walnuts daily. Add a rainbow of vegetables, dark leafy greens, orange squash, purple cabbage, and 2 servings of berries per day when possible. Choose olive oil as your default fat. Include quality protein at each meal, beans, lentils, eggs, yogurt, poultry or fish, to steady blood sugar and mood. Ensure B12 sufficiency. Older adults absorb less from food, so include fortified foods or talk to your clinician about checking levels. Hydration matters. Sip consistently through the day, then taper after dinner. And caffeine timing is huge. Coffee lovers consider a half-caff morning and stop by noon. This alone can reduce the need for sleep meds in many people. Let's knit everything together with a 14-day action plan you can start today while you wait for your appointment. Days 1 to 3, gather every pill bottle into a bag, including OTCs and supplements. Create a simple log name dose, why you take it, and what happens if you miss it. Start a symptom tracker for sleep, mood, bladder urgency, and daytime energy. Days 4 to 7, audit your OTCs. Replace first-generation antihistamines with non-sedating alternatives after a quick pharmacist check. If you've been taking a PM pain reliever for sleep, talk to your pharmacist about switching to a non-PM version at the same dose for pain and work on sleep hygiene. Begin a morning daylight walk and keep a consistent wake time even on weekends. Days 8 to 14, meet your clinician for a medication review. Ask which single medication change would lower your anticholinergic burden the most. If a taper is indicated, schedule it and know what withdrawal signs to watch for. Meanwhile, lock in your food-first plan, Mediterranean-style meals, evening caffeine cutoff, and a modest earlier dinner to support sleep and reduce nighttime bathroom trips. Safety caveats that can't be skipped. Some medications on this list are absolutely necessary for certain people. The goal isn't zero meds. It's the right meds at the lowest effective dose for the shortest needed time. Never stop benzodiazepines, antipsychotics, antidepressants, or opioids. Abruptly rebound anxiety, insomnia, withdrawal, or pain crises can be dangerous. And don't assume every memory problem is medication-related. Infections, dehydration, thyroid issues, low B12 sleep apnea, depression, hearing and vision problems, and uncontrolled diabetes can all cloud thinking. If confusion appears suddenly, it's a same-day call to your clinician or a trip to urgent care. Because you stayed to the end. Here's a quick checklist you can read to your pharmacist today. Please look for diphenhydramine or doxylamine in any of my OTCs, especially PM products. Check my total anticholinergic burden and tell me which items are the strongest contributors. If I'm using a bladder anticholinergic, is there a non-anticholinergic option or non-drug therapy I could ask my doctor about? If I'm on a benzodiazepine or Z-drug, what are safer sleep or anxiety strategies to discuss with my clinician while planning a taper? Are there any drug-drug or drug-alcohol interactions that raise fall or confusion risk? Take notes and bring them to your appointment. Let's close with a simple memory formula you can share with your family. Less ACB. Better brain review, replace reassess. Review every pill. Replace the heaviest offenders with safer strategies and reassess regularly with your care team. If this episode gave you language and a plan, please tap, share it with your family group chat, and subscribe for more science-based food-first guides for healthy aging. And tell me in the comments which topic you want next, a step-by-step sleep taper plan with your doctor, or the ultimate bladder calm grocery list that still lets you sleep through the night. Your brain is worth protecting, one smart supervised change at a time.